rotator cuff is actually those small muscles in your shoulder.
Right now, I have no evidence to really definitively tell you that they will help you.
Arthritis is where you have breakdown of the cartilage in the joint.
And I do think that we are starting to see a pretty good improvement of healing rates because of these advancements.
I think the most common reason I fix rotator cuffs is because people are like, I can't sleep.
So have you ever seen someone dislocate their shoulder after a bad tackle or just slipping and falling on the ground?
Welcome to the Shoulder Blueprint, the podcast built to help you understand the shoulder, how it works, why it hurts, and how to fix it. Here are your hosts, Dr. Caleb Davis and Dr. Justin Givens.
Hey everybody, and welcome to the first ever episode of the Shoulder Blueprint podcast. I am your host, Dr. Caleb Davis, and this is our co-host, Dr. Justin Givens. We are both shoulder and elbow fellowship trained surgeons, and our passion is the shoulder. Now, I've had a big passion for podcasts as well, and my thought with this new podcast was, well, how can I bring one of the smartest shoulder surgeons I know into doing podcasts with me?
Oh, stop. You're too flattering.
And the other was, how can I explain my passion for shoulders to my patients and my friends and my family and try to really break down a pretty complex topic and something that's easy to understand for everybody? So I couldn't think of anybody better than to bring Dr. Givens on the show with me and do our very first episode talking about the rotator cuff. So everybody's heard of the rotator cuff, but I think a lot of people probably don't even know what it is. Dr. Givens, I'm going to throw it right to you. Tell me, give us a breakdown.
Yeah, so I'm very open. Look, I was raised in the middle of nowhere, Kentucky. I didn't even start speaking English as my first language until a couple years ago. So the rotator cuff, completely foreign concept to me. So the rotator cuff is actually those small muscles in your shoulder that create the motion in our shoulder joint and provide stability. So most people talk about the rotator cuff as a single thing, but there's actually four muscles. There's one in the front, one on the top, and two in the back. The one that we always talk about is that one on the top. That's the one people love to tear, and the fancy doctor word for it is the supraspinatus. But there's some other important ones too. So you might hear about the ones in the front a little more in people who dislocate and things like that.
So the most commonly torn muscle in the rotator cuff is the supraspinatus, the one on top that you talked about.
Correct.
It's so funny. I have so many patients who come in with shoulder pain. It can be anything, AC joint arthritis. It can be just impingement, tendonitis. And pretty much everyone asks me, is like, Doc, is it my rotator cuff? Sometimes it is. Sometimes it's a tear. Sometimes it's inflammation. Sometimes there's a lot of different things. But I think this is a really helpful topic to just dive into the nitty gritty, but still make it understandable. Let's talk a little bit more about the shoulder anatomy, though. So it's a ball and socket joint.
Ball and socket joint, but a really shallow socket. So it looks like a golf ball on a tee compared to that hip that has a lot of constraint around it.
And because it's such a shallow socket, that's what gives us our mobility, why the shoulder is the most mobile and flexible joint in the body.
100%. The shoulder is one of the few things that actually doesn't just turn, it also slides. And that's what allows us to get more of that mobility as opposed to all the other joints, which they're pretty tightly contained.
What I've always loved most about the shoulder is I like to think of it, it's what puts our hand in space. It allows us to move our hands and put it anywhere we need. Without the shoulder, you don't think about it, but once that shoulder is not working right, you can't do anything right anymore.
Oh, 100%. I mean, I went through this when I was younger. I actually had to have shoulder surgery. And being a 20-something-year-old guy who couldn't use their strong hand and just had it locked down in a sling for 7 weeks was miserable. I mean, you just didn't feel like you were human half the time. You couldn't put your own shirt on or anything. It was crazy.
So since the shoulder is the most flexible but also has a shallow joint, the rotator cuff is called a dynamic stabilizer. That's what gives its inherent stability.
Well, tell me that. What's a dynamic stabilizer, Dr. Davis?
What we think is static constraints like fixed objects that keep the ball and the socket linked together. In the hip, it's largely bone and labrum. But the rotator cuff dynamic, we mean that it's constantly moving and shifting. And if you think about a shallow cup that allows a ball to fall out, if that rotator cuff is torn or compromised in any way, that ball is more prone to move out of position and not be able to stay in a ideal position to be able to move it in space correctly.
Yeah, and I think that kind of goes back to what we talked about, why we see so many rotator cuff people or people asking questions about the rotator cuff, but it being another problem. That's all muscular driven, and muscles love to shut down whenever there's inflammation. So whether the problem is the rotator cuff or the problem is some other form of inflammation, that muscle down regulates. And we see this a lot more and talk about it more in the knee than in the shoulder. But then it makes it where you can have some inflammation in your shoulder, but your rotator cuff shuts down a little bit, so you're not making it worse.
So even if your cuff is not necessarily torn, you might still be having problems with it that are causing you to lose motion.
100%.
Yeah, and we see that a lot. Probably the most common thing that I see in my office is something called impingement or just inflammation of the tendon. There's a lot of debate on that. I don't want to get into the impingement debate right now. But you don't necessarily have to have the tendon torn from the bone, but it can still be dysfunctional, causing you significant pain, so you can't use your shoulder correctly.
Yeah, we see this more. It's better explained in the knee. So this is what ends a lot of NFL running backs' careers is they'll have inflammation in the knee, and that inflammation sends a feedback loop to the spine and just says, hey, there's a problem here. We need to decrease the muscles in the leg and how they're firing so they don't run and jump and do things that can make it worse. It hasn't been studied as much in the shoulder, but we know that those loops exist in the body. It's your body's own way to protect itself.
Yeah, and probably most people here have experienced, whether they know it or not. Let's say they get a bruise on their leg and they try to flex that muscle. It hurts.
Yeah.
Like you don't want to do it. Or if you have a big swollen joint after an injury, your body actually keeps you from flexing that muscle, and it's a protective mechanism so you can heal from that injury. And the same thing can happen in the shoulder.
100%. Because some of us need our body to tell us that because we're not smart enough to stop from doing it on our own.
Yeah, most of us meatheads will just keep on going.
It's the only way to get stronger.
I want to talk about some of the other pain generators in the shoulder, or let's say places that I commonly see patients have complaints. So I'm going to break down the anatomy a little bit more. We talked about the ball and socket joint, which is also called the glenohumeral joint. There's also the AC joint, which a lot of people have probably heard of, a separated shoulder, especially football players and other contact athletes, where the collarbone comes and meets the shoulder, and that joint can be disrupted.
So where would that be on your shoulder?
So as your collarbone comes across over to your acromion, kind of on the outside portion of the shoulder, that's your AC joint.
And what's that A word you're saying? What's the acromion? I know what my collarbone is, but what's this acromion thing?
It's a great question. Yeah, and I don't think I knew what the acromion was till I was in med school.
I still sometimes question it.
So the collarbone, most people know about the collarbone, are also called the clavicle. But then your acromion, if you touch the very far outside of your shoulder, that's the acromion bone, which is part of your scapula. The scapula is the big part of the shoulder blade, and there's an outgrowing of bone that slopes over top the head of your humerus, the ball and socket joint. And that's the acromion.
Yeah. So what I like to think of for the acromion's big job is the attachment of the deltoid muscle. For all the meatheads out there with your boulder shoulders, that's where they start is up at the acromion, and then they come down, and that deltoid connects to the humerus.
And that's a big, broad muscle that has lots of points of origin, but then inserts into your arm that allows you to lift up to the front and to the side. Although the rotator cuff sort of initiates that motion, the deltoid takes over as you get higher and higher.
So then let's go into the thing we all love. We want to have those big biceps. Tell me about the bicep. How does it play a role in the shoulder? Where's it at?
Biceps is probably one of the most common pain generators we see in the shoulder as well. As the name may clue you in, biceps means two. The muscle that we're all familiar with, the biceps, actually has two tendons that branch off and they come up into the shoulder. One goes closer inside the shoulder onto a bone called the coracoid. The other one's called the long head of the biceps. It actually travels right through your shoulder joint. It's one of the few tendons that goes through a joint. That's a trivia question sometimes. What's one of the few tendons that travels through a joint rather than inserting above or below a joint?
My trivia team's going to appreciate you giving me that answer now.
Spoilers right there. Is that a question on upcoming trivia?
Oh, I don't know, but if it is, I'm getting it right.
Apparently we do an office trivia like almost every day, right? I've
not been included, I guess, because I would win.
They told me I couldn't play. I think it's
that
not,
sounds about right.
It's not for the doctors. So the long head of the biceps is often a significant cause of pain. It presents just as pain right in front of the shoulder, oftentimes with lifting straight up into the air with your palm up. And a lot of times it just aches and aches and aches during repetitive motion.
Yeah. So bicep, huge pain generator, see it a lot. And then that brings up the next question, though. I hear about this bicep labral complex. So what's the labrum? Because everyone's labrum is torn whenever they get their MRIs, it seems like.
Yeah, labrum's another one that people talk about a lot. That's another buzzword. I don't think it's quite as known as the rotator cuff, but it's an equally important structure. So the labrum, if you talk about the socket, it's a shallow golf tee. There's a ring of tissue. I like to call it the O-ring. Ring of tissue that goes around the socket. That helps make the socket just a little bit deeper, helps offer a little bit more stability to keep that ball from popping out. So have you ever seen someone dislocate their shoulder after a bad tackle or just slipping and falling on the ground? The ball pops out the front typically, and that ring of tissue can become torn. That's known as an anterior inferior Bankart labral tear. The tear I think you're talking about is probably called a slap tear.
Oh yeah,
And
I hear them all the time. I got a slap tear, doc.
And quite honestly, you can see them a lot. The biceps attaches at the very top of the labrum and it's connected. So if you do have a torn labrum, that biceps is pulling on it, pulling, and that can cause quite a bit of pain. The funny thing is, though, if you get an MRI of anyone over the age of 50, they probably have some form of a slap tear. Now, that's going to vary from person to person, but not every single person is having pain. But it's just sort of the natural degeneration that our bodies go through over time.
Yeah. And I would say that you even would take that younger for just in general degenerative labral tears. If I get an MRI over the age of 35 on someone, I tell them you are most likely going to have some form of quote unquote labral pathology. It degenerates earlier than the rotator cuff and start to have degenerative tears without really having symptoms at a much earlier age, it seems like.
But I had planned, you didn't know this, but I had planned to do an entire episode on the labrum, so I'm going to stop there.
Oh, man.
That's just a
spoiler if you want to learn about the labrum in the future.
That's just a teaser. Hey, we got to save some stuff to talk about. You know, the shoulder's a finite thing. I'm planning 3 seasons of this podcast.
Well, and you know how much trouble I have talking, so we really got to save whatever we can because I can't talk long.
No, Justin's very shy.
Yeah.
If you can't tell. All right. So we've established a little bit of the basic anatomy of the shoulder. We've talked about some of the things that cause pain, but let's focus back in on the rotator cuff. We've described that it's 4 muscles. It's essential for motion, stability, and overall normal kinetics of the shoulder. What would you say is the most common reason someone has a torn rotator cuff?
So the most common reason is when we go back to talking about this degenerative situation. So we know that as we age, our blood flow to the rotator cuff decreases. Because of that, we're much more likely to have these degenerative tears that form. So there's really good data on this that actually shows if you have a normal shoulder, no injury, no surgery, no nothing, and we get an MRI at 60, there's a 50% chance you have some form of partial thickness rotator cuff tearing. At 70, it's 75%. At 80, it's 85%. And at 90, they couldn't find anybody that didn't have shoulder pain, so they stopped there, I guess.
I started having shoulder pain when I was 18, so it's just continued since then.
Oh, well, so, the good news is yours is not degenerative. You just messed your shoulders up. So, at least you know the answer, right?
I think I'm going to hit the entire shoulder bingo checklist if I ever get an MRI of my shoulder, which is exactly why I'm not getting an MRI of my shoulder.
Yeah, I was going to say, I've already hit the shoulder surgery checklist, but it was for my labrum, but I'm sure my rotator cuff is hanging on in its own way too. But that's the most common thing we see. The thing that people hear more about, though, are the traumatic tears. The person who fell on their arm or they fell off a ladder or grabbed something heavy, because normally that's what makes people come in with the significant loss of function. My degenerative tear patients normally come in and their shoulder aches and it bugs them and they've lost some motion and function and strength over time. My traumatic patients, they were fine, and then 10 minutes later, they couldn't lift their arm. And those patients normally are the ones who feel like they have that biggest life impact, at least in the short term.
Yeah, and that's the key. And I'm glad you touched on everything I wanted to talk about. Most patients do not have an acute traumatic event that caused their cuff tear. So a lot of times I get an MRI and their cuff is torn. They're like, but I didn't fall. I didn't have an injury. How could this be? That's actually the most expected outcome. And a lot of times people do come in with a trauma and they certainly can have a tear as well, but it's just not the most common thing that we see in our practice.
Now, can I ask a question?
Yeah.
I have a patient that came in and they had an acute on chronic rotator cuff tear. What does that mean, Dr. Davis?
So acute on chronic would mean that there was probably a pre-existing tear that existed before the injury, before an MRI, but something exacerbated that. It could have been a fall. It could have been they slept on it wrong. But it could be a number of things. But it's something that was pre-existing but was made worse by something.
And this goes back to those people who had a rotator cuff tear. We talked about in your 50s, in your 60s, in your 70s, you have a degenerative tear. And it's kind of been slowly causing issues, but not enough that it bothered you. But then they have a big injury, and it's just like the straw that broke the camel's back. And unfortunately, then we have to talk about, hey, there's some of this that is old and there's some of this that is new. That changes the treatment a little bit at times, depending on how bad the old tear was, what the muscle looks like, and things like that.
And on that topic of acute versus chronic tears, we can get into the nuance of this if you like, but in my experience, somebody comes with an acute traumatic tear, the best thing is to fix it. In most situations, there's going to be exceptions to that. When people have a chronic tear and they have good function, they're able to use their shoulder the way they want, they just have pain, there may be ways to treat that without necessarily doing a surgery.
That's totally right. My question is, when you say it's best to fix the traumatic tears early, is there anything that would back that up?
I'm basing that based on what level of function they had before and what level of function they have when they see me.
Yeah, well, and there's some good data on this, though, too, that shows that those acute traumatic tears, so hold on, step back here. Rotator cuff tears are notorious for, as they get bigger, having some trouble healing, even if everything is done well. There's a lot of force pulling that tendon away from the bone. And so we talk about healing rates all the time. So if you have a degenerative tear and you already have bad blood flow, getting the blood flow you need to get the rotator cuff to heal well can sometimes be a problem. But what we found in looking at the data is that patients that have a traumatic tear, if they're fixed in those first 3 or 4 months, they still have that good blood flow to their rotator cuff and typically have a better chance of healing, which is the reason we talk about, they go from this to nothing. But then also, if we're going to fix something, we want it to have the best possible chance to heal. So we might not drag that down the road quite as much as someone who has a tear that's been going on for 5, 6, 7 years and slowly getting worse.
That's an excellent point. And we do have a similar approach to things when we deal with fractures, like broken bones.
Yeah.
You want to fix it quickly. You have good blood supply. You have inflammatory changes that actually can promote healing. If you take advantage of that biological environment quickly, then you can have a better outcome. Where if you go back 6 months later, you might not necessarily have good blood flow and good healing potential. And we see that even in young patients sometimes.
Yeah, 100%. Unfortunately, I do more young patient non-unions than I ever would like to.
And a non-union is when a bone fails to heal.
Yeah, sorry, excuse the jargon. I don't think about it sometimes.
He pretended he wasn't smart earlier, by the way. That's just an act. That you made a great segue. One of the biggest challenges as surgeons, as shoulder surgeons, is getting the rotator cuff to heal. And we've sort of touched base on this already. The poor blood supply to the shoulder makes it so that we can't get those healing factors from that our body can provide to allow that tendon to heal back to bone. What are some ways that we are starting to improve on that?
Oh, so this is a long and can get in-depth conversation.
We'll try to keep it granular.
So we're going to try to keep it granular, and then I'll kind of give a nerd alert if we're going to go too deep here.
I'll stop you.
Yeah, that's okay. But so the biggest problem used to be how we attach the anchors and the rotator cuff to the bone. And so over the last, 20 years, we've drastically improved that. So we created new anchors, we created better fixation, we created things that don't react to the bone. So the problem was you could have problems with bone reactions that would let the anchor come out. So this is your point of fixation. So you need a good screw, essentially. You got to be able to hold something together. And so that was where the failure used to be a lot of times. So we've made some big advances there. Now the problem comes more with this tendon. And actually getting this tendon with good blood flow to, one, be strong enough that it holds the sutures in it. So we normally put an anchor into the bone, we put suture through the tendon, and then we use that tendon to pull it back down to bone. So used to the problem was the anchor holding in the bone. Things have come a long way with the anchors we use during surgery and how we do it arthroscopically. And so now the problem tends to be more at where that the suture goes through the tendon and it can tear out.
So I'm going to summarize that in a little bit more plain speak. We would pull the tendon to the bone, and then where we fixed it to the bone would pull out back in the day.
Back in the day,
Now, our technology got a lot better. So now we're able to pull that tendon down to the bone, but the rest is up to the tendon. The tendon has to heal. We fixed it. Yep. It's kind of like you can lead a horse to water, but you can't make it drink, right?
100%. And so then you get into a much deeper debate on biology and mechanics and things like that. But the biggest failure point at this point in time is that tendon going through, or the suture going through the tendon. So if you can imagine, if we pull the tendon down to bone with the suture and the suture rips out of the tendon, well, the tendon's going to go back away from the bone where it was. And so there's multiple ways that people are trying to come up with to fix that. And so it's something you might hear about with a rotator cuff repair is patch augmentation these days. And that gets into its own realm because there's different types of tissue that we'll put with the rotator cuff repair to try to help it to heal. So some people do that by adding a patch. Other people just do what's called biologic augmentation. So some guys use things like platelet-rich plasma or PRP injections.
Probably a lot of people have heard of that, where they They spin down your own blood into a centrifuge and get a concentrated filled with platelets and other healing cells and inject it around the repair site to try to help the chance of it healing.
Yeah. And so all of this being ways to help strengthen the tendon and help to increase that rate of the tendon healing back to the bone.
Now, the funny thing is this is all really new. It's conceptually been around for a couple decades, but it's really exploded in the shoulder industry recently. You put 50 shoulder surgeons at a shoulder conference in a room together, we might break out into a fist fight on which is the best which is the best approach. Is it mechanical fixation? Is it biologic? Is it injectable? And there's just so much debate right now. But I think the thing that's so cool about this is just that there are so many people like us who are nerding out and are sitting in labs doing these experiments and trying to figure out what is the best way to get rotator cuffs to heal. I don't know that we have 100% definitively this is the answer yet, but there's people like us tirelessly trying to figure it out. And I do think that we are starting to see a pretty good improvement of healing rates because of these advancements. And my takeaway from this is there are surgeons who are forward thinking and trying to reinvent the wheel, so to speak, in ways of what's been a marginally successful surgery, turn it into a home run.
Yeah. Well, and I think this is where we don't talk enough about how new some of the stuff in shoulder is. So shout out to my guy, Chris Okuma. So he's one of the guys that helps me in the OR. I always joke with him. He's been around the scope game for a long time. To give you an idea, I joke that, hey, dude, when he started, he was looking through little holes in the original scopes. And that was like 20, 30 years ago. Like it's really, it hasn't been around that long. Like we talk about anchor failure problems. We're talking like late 90s, early 2000s. Like these things are, we're not super old. These things are younger than us. Shoulder replacements, well, don't get me to what I feel
That's
like.
probably because of the powerlifting.
Yeah, I was going to say my chronological age and my physical age are different, right? But whenever we start talking about these things, like shoulder replacements have been around for 21 years, the reverse shoulder replacement in the U.S. Arthroscopic rotator cuffs, everyone was getting it open back in the 90s. Mm-hmm. And so when we start to realize the strides that are being made in such a short time, it's like, wow, this is all new and rapidly advancing stuff when you compare it to things, surgeries that have been around for 60, 70 years and being done very similarly.
Yeah. That's really kind of my moment to just be like, man, it's so cool. It's so cool the things that we're developing in shoulder surgery space. One of the reasons I decided to specialize in shoulders because to me it was the Wild West frontier. It's like there's so much stuff that's happening right now that's developing into this burgeoning field that I think that it's almost like the advent of the computer. Like it's going to start, it's just going to explode. So I'm just so happy to be a part of it.
I think it is absolutely crazy. I mean, we are from the beginning of our practice until the end. I think we will be doing almost every surgery completely differently. And I mean, that's what we see. That's what we're talking about right now. When you start talking about some of these biological augments, when you talk about, robotic shoulder replacements, when you talk about, people wanting to put sensors in to determine the active tension of the rotator cuff after repair, it's like, holy smokes, this stuff is insane.
Yeah. It's just, it blows my mind sometimes, but that's our little nerd out moment. I'm going to try to get a little bit more focused in. That's my fault. Wasn't me. I'm going to try to get a little bit more focused again on something that's a little bit more applicable to the patients. So what are some of the common symptoms of a rotator cuff tear? So, whether it be a chronic or an acute traumatic, what are some of the things you might experience to look for? Maybe you want to go see a doctor to consult about it.
Yeah. So biggest things the big thing is weakness. Losing that muscle at the top. You'll have some people that have really good maintained motion, but that weakness of lifting out away from the body. And that's important because what you'll have is some people are like, I can do everything in here. Because if you keep that elbow tight against the body, you don't have some of the issues with the rotator cuff needing to be engaged. The arm can be stabilized against the body and you don't need the rotator cuff to stabilize. So they're using their biceps and triceps and shoulder shrug, and they're not really needing their rotator cuff for that.
That brings another important point. Is there other muscles that can contribute to stability? They're not as important as the rotator cuff, but the pec major, the teres major, the latissimus, the deltoid, all these things can sort of help compensate depending on the degree of your tear. Well,
and very positionally based. Mm-hmm. So in certain positions, they can provide more stability, and in other positions, they can't. And that's where things really come in as far as lifting. So the one thing I always talk to my patients about is putting a gallon of milk in the top of the fridge, because trying to lift up and out away from the body is one of those things that really the rotator cuff has to provide a significant amount of stability for, so that the deltoid can do the lifting. And if the deltoid's trying to do the rotator cuff's job, it's really hard for it to do its own.
One of the things people don't appreciate either, I think, a lot is external rotation. Like being able to rotate out this way. A lot of times I'll test that in the office and they're like, oh, I didn't even realize that was so weak.
You don't know what you got till it's gone, right? There's a whole song about it, and you don't realize how important that is until you can't reach in the back seat to hand something to the kids, until you can't grab your lunchbox out of the passenger seat. All those things, right?
It's funny, the things you and I hear every day. You don't ever think about it, but we hear it 50 times a day. So it's like, oh yeah, I know what you're talking about.
Yeah, it never fails. It's ladies can't hold their blow dryer up, so you got to lift your arm and turn out to hold your blow dryer up. When you can't blow dry your hair, their husbands are always terrible at it. I hear it 100 times a day. They're not doing it right.
Man, I wouldn't even want to try to do that.
That sounds miserable. I don't, I'm not trying to do that for my wife. She's really good at doing her hair. I don't want her to need me to help. If she has a shoulder problem, I'll bring her to you so you can fix it.
There you go. Nice to have a partner you can trust.
That's right. So strength, big one. Pain is the other big one.
Pain at night.
Yeah, especially
big
at
one.
night. Yeah, that nighttime pain. And it makes sense if you really break it down. So you think about during the day when these bigger muscles are active and they're doing everything, they're trying to offload the rotator cuff. But we all know what happens at night, right? We relax, those bigger muscles relax. Your small stabilizing muscles don't do that. So your rotator cuff is always working a little bit, making sure your shoulder's not coming out of place. So all day, your deltoid, your lat, your pec, they're helping out. They're keeping it stable. They're doing the rotator cuff's job. And then you go to sleep and you finally relax and your rotator cuff's like, whoa, I'm torn. I don't want to do this by myself. And that gets that nighttime ache going.
The other analogy I like to tell people is like, you're flat on your back. Gravity's no longer pulling down your humerus. That rotator cuff on top is now your shoulders are sort of pushing right up into it.
Oh, yeah.
Or if you're a side sleeper, we get that a lot too. You sleep on your slide, super painful now.
Which is why people like the recliner. That's a great analogy too, because most people will tell you, oh, I got to sleep in a recliner. My shoulder's hurting so bad, or something to that effect.
So some of the ways that we look for rotator cuff tears. Now, the patient comes and tells us a story. Either I just woke up one day and it was like this, or I fell and had an injury playing football, whatever you want, whatever it may be. We have different ways we do maneuvers called physical exam maneuvers, and they all have names of dead doctors.
That's exactly
we got
what they
Hawkins, near speed jobs. We have all these different test names, but essentially we're doing different things that test the different functions of the rotator cuff muscles, or things that we expect to elicit pain. Which, yes, it is our job to make you hurt a little bit, just for a little while, so we can figure out what's bothering you.
Not hurt in the future.
What's funny is back in the day, before MRIs became prevalent or even existed, this is literally all they had to go on. This is they call it the art of the physical exam, and they say it's a dying art.
100%.
Now, the thing about the shoulder exams, as useful as it is, and we do it every single day, there is something called sensitivity and specificity. I'm not going to get in the weeds on that, I promise. But essentially, one test may be positive for 7 different conditions.
Yeah.
And that can make it tricky. But lo and behold, we have beautifully quality MRIs these days, and we can usually get them within a week or even shorter sometimes.
I don't know what MRIs you're getting. Not all of mine are beautiful quality.
Depends on what facility you're getting them. So some of the MRIs are beautiful quality. Yes, not all MRIs are created equal. You may want to ask your doctor about that. Yeah. Where to get your MRI done, and they'll say, oh, this place, because I look at the MRI, and that's a good MRI.
Please, it helps us a lot.
And I will tell you, I don't make any extra money based on where the MRI gets done, so at least I don't think I do.
You don't. I don't. If you do and I don't, I have problems. We're supposed to be partners after all.
So that may be something you may want to consider. I've definitely had patients go somewhere else and say, please don't go there. I have nothing personal against them, but I've seen the MRIs. I just can't see anything with it. That's a little bit of a tangent too. But the MRI, we can look at the rotator cuff. We can look at the biceps. We can look at the labrum. And the MRIs have gotten so good now. It used to be you had to inject dye into the shoulder. I'm getting more and more away from that, where injecting dye to be able to see the structures better is not nearly as necessary as it used to be.
Yeah, the places that I really reserve dye for are my young patients with labral injuries, but then also if you've had a rotator cuff repair before. So when your rotator cuff heals, we know it doesn't heal exactly the same way as it was before. And so sometimes, especially if the MRI is not the highest quality MRI, it can look abnormal whenever you look at it on MRI. So if I'm looking for a re-tear, I normally do contrast because the contrast will show me if there's a spot it's not healed down. Because sometimes the rotator cuff can still look like it's in a pretty good position, but then because the sutures are holding, but it hasn't healed. And that dye will kind of make that come out. But I agree. Those are kind of the special situations where I'm looking for dye, and otherwise I'm not using dye really at all for my rotator cuff.
There's still a time and place for it, for sure. It's just not my standard routine of care anymore because of the advancement of technology. But still, labral pathology, we'll get more into that next episode, I think. Yeah. There may be an episode 2 on rotator cuff the way we're going.
I was going to say, at this rate, we got a lot to talk about. I mean, the rotator cuff's a pretty important thing after all.
So we've covered what can a patient expect to look at, like maybe they're concerned they have a rotator cuff. We talked a little bit, how do we diagnose it? We do different physical exam maneuvers. We get an MRI. So when should someone consider having a surgery to get it fixed? Because we already said that maybe not all of them need to be fixed.
Yeah. So I think this is hard, and I think it comes down to kind of what your symptoms are and having that discussion with your doctor. One of the other things that comes into play sometimes too is other pathology, or other problems. So we have a lot of people that they'll come to me and have a rotator cuff problem, and maybe that alone didn't need anything, but their biceps partially torn, they have this terrible inflammation in their AC joint, and so they have multiple pain generators.
Not to mention neck pain or other confusing symptoms.
The neck pain, you can go down a rabbit hole all day. And so I think the biggest thing is that I tell all my patients this. Look, I'm a quality of life doctor. There is no thing that I do that saves your life. And so I'm not a heart doctor. I'm not a lung doctor. If we're doing something, it's to make your life better.
Yeah, we do fix the occasional hip fracture. I like to take credit for that.
I do fix the occasional hip fracture, but even still, I consider myself a quality of life doctor. And
I like the humility doctor. I like it.
Yeah. And so whenever we start talking about that, that's a lot of this discussion. So I think you could really get into the weeds about big traumatic tears and talking about atrophy, which we may talk about more later. But for most of these patients, the question comes down to, how is it affecting your life? When you can't do your job, when you can't rest at night, sleep is the biggest one. I think the most common reason I fix rotator cuffs is because people are like, I can't sleep. And the health benefits of good sleep, you quickly realize what they are when you aren't getting good sleep and waking up every 2 hours and you feel draggy and fatigued and you get the weight gain and all these other things that come with it.
I did 2 episodes on sleep at my other podcast. A little plug to the Wellness Blueprint podcast.
Shout out Wellness Blueprint.
where it all started, right?
Yep.
So I think that's a great point. And something I like to tell my patients is I'm treating a patient. I'm not treating the image, meaning the MRI. So many people, I'm not trying to throw shade on anybody in particular, but you're tempted to, you have a rotator cuff tear. You need surgery. We're going to fix it. Yeah. Every single person's different. Their quality of life's different. Their demands, their expectations, what they want to get out of life is different. And it's our job as surgeons to sit down and with them, manage expectations and see what it is they want to do. Yep. Just like you said, if someone comes in, you find a rotator cuff tear, they're not having that much pain. They all they do is like to play a little bit of golf. They're not a mechanic doing overhead work. They can do mostly what they want to do. Maybe we can get them into some rehab, give them a little bit of strength and range of motion back. They might do just fine.
Yeah. And I think that's the easy one, right? The easy one is when they're not having pain. I think that makes the decision. There are very rare cases where I will tell people who are having limited symptoms that they should have a surgery. And they're very special circumstances normally. The hard ones are the ones that come in that have a tear and they came to you because they're having significant problems.
Which is most people.
Which is most people.
Yeah.
It really is. And so that's when we start going down. I think there's kind of a couple crossroads, right? So like the first crossroad is this acute or recently happened? Is this degenerative long-term problem? And so I kind of told you those acutes, especially if they're a full thickness tear, we know how much they have trouble with healing later on and they heal well early. I'm maybe leaning a little more towards surgery, but I tell everyone my favorite one is I always say, hey, if grandma just wants to sit in the chair and knit all day at 80, how much do I need to do this surgery? There's still people that maybe that's not the right answer for them. But then you start going down the degenerative path, and then you start asking all these other questions, right? Like, well, what does the muscle look like? Is there atrophy? What is their job? What do they need their arm for? Is someone coming to me because they're occasionally sore when they play 17 games of pickleball, but they don't have to do that? Or are they coming to me because after they're an hour into their 8-hour job, they're in excruciating pain and they can't do it anymore? So all of those things kind of come in. And what have we tried? Have we tried therapy? Have we tried anti-inflammatories? So back to you, what are the options if I have a rotator cuff tear and I don't want to do surgery?
Yeah, and I will tell you that there's a whole gamut of options, but I do my very best to discuss them with every patient, even if I think they need surgery, because I want the decision to be theirs. Yeah. Physical therapy is a big one. Just having supervised exercise program that can help not only strengthen your rotator cuff, your deltoid, your scapular muscles, give you put you in an optimal position to heal and be able to have functional recovery.
But my rotator cuff's torn, doc. How is therapy on it going to help me?
That's a great question. I hear that a lot. There's also difference between tears. I don't think we even got into partial versus full thickness tears yet.
No, we haven't.
That might just be too much for this episode, quite honestly.
Yes.
I'll be very brief. The rotator cuff, all four muscles joined is one big, thick tendon. The footprint is really, really wide apart, and it's also very thick from top to bottom. And you can have some partial tearing, but not torn all the way off the bone. Those are sometimes the hardest cuff tears to deal with because you're like, what do I do? Do I operate on this? Do I not? And we're not going to get into that this episode.
Plug for the future. We will talk to you about our techniques for rotator cuff repair, including partial thickness tears, cool things called pastas, how we treat all this stuff. That's another show.
You can tell how excited he is already, by the way.
Such a nerd. I love it.
But it gets into some controversy. I think therapy is very helpful, even if it's just for the education of having someone sit down and teach you how to exercise and rehab. Yes, if you have a full thickness rotator cuff tear and it's torn off the bone, the chances of that tendon healing back to your bone on their own is almost zero. That's true. If it's a partial tear, it could heal potentially. There's controversy on that too. But you can have compensation of the other muscles and you can strengthen what muscle is remaining and have a healthier dynamic shoulder with all of the surrounding stabilizing muscles be healthy, and you can have a better outcome and have less pain because of that.
So like what I like to tell my patients is that the tear can sometimes stabilize. And so you have a tear, we see this in older patients where they've got a full thickness tear that they've had for years but had no issues because other muscles have picked up some of the slack from the tendon not being normal, and the tear is not continuing to progress. And so that's kind of my thought on if the tear stabilizes and you can function and do the things you need to, you might not necessarily always need surgery even though the tendon doesn't fully heal.
I'm going to play off that, and we're going to talk about those chronic tears. People had chronic tears for years and no pain. Now they have pain. Why? What happens when we get older? Our muscles atrophy. We lose strength. We lose stabilizer muscles. And now the shoulder is less stabilized, and now it's starting to cause pain. So you can think of that reverse analogy and say, if I keep strong all these surrounding muscles and keep a healthy dynamic shoulder, I may stabilize this tear where it's not going to cause me as much problems down the road if I do nothing and ignore it. Unfortunately, what most people do is it's just part of aging. We atrophy, we don't keep up, and things just start degrading.
Yeah, most common place I feel like I see people with new shoulder pain that come in that just have these tears that look terrible is after hospital admissions, long-term sickness, or cardiac surgeries. Because it's exactly what you said. They get deconditioned. The muscle that was trying to help, and their 3 or 4 muscles were doing 2 jobs to make up for it, they start to fatigue, and they're like, hey, I can't do your job anymore. I got to focus on just my job. And next thing you know, they're having trouble.
So let's say you've got a full thickness rotator cuff tear. You've tried non-operative management, and you're going to have surgery. I'm going to give you my spiel, and I want to hear your spiel.
Okay. Well, hold on. We're going to go here. You haven't even talked to me about injections yet, Dr. Davis. I don't know anything about NSAIDs. Can I not eat ibuprofen for a little while and put this down the road?
You make a great point. We'll pull back there a little bit. It's a good doctor, by the way. That's a good surgeon, not trying to rush to surgery.
If I can make you better by not cutting you open, I'm a better surgeon.
Now we're going to get into some of the even more controversial topics, and people get a little bit scared of NSAIDs and steroids, right?
NSAIDs first. Let's do NSAIDs because the injection can go a long road.
Okay. NSAIDs, nonsteroidal anti-inflammatories, act on the body to reduce inflammatory pathways. We can get a little bit more specific. It's a cyclooxygenase enzyme that reduces all that. But the name of the game, most people have taken ibuprofen, Aleve, things like that. Over the counter, you can get it. It's not a controlled substance. Most people have taken it for a headache or aches and pains. It can help with the pain quite a bit. It can help with inflammation. It can help with swelling. It's not going to heal your tendon though. However, if you can get enough of that pain under control that you can get through a rehab protocol and get back to normal, sometimes that's all it takes. The side effects and dangers, I know you're jumping to talk about it, so why don't you go for it, Dr. Gibbons?
Oh, yeah, this is one of my big things. So this is where we go back to talking about that inflammation in the joint and down-regulating muscles. So that's the whole point of the NSAID, is to get that under control so the rehab can actually work on strengthening the muscles. The problem is what comes with it. So once again, if I'm not saving your life, putting you on a long-term treatment that can cause risk to things like your kidneys and your stomach is not where I should be stepping into play. So I like to use these short-term. So for a couple weeks while we're trying to get therapy started, while we're trying to calm things down enough that some of the other muscles can pick up. Because when we start taking NSAIDs, we can have problems with our kidneys, we can have problems with our heart, we can have problems with stomach ulcers. A lot of patients come to me and they already are not allowed to take NSAIDs. They have cardiac problems, or it thins your blood a little too. So patients on high-level blood thinners really shouldn't be taking high doses of NSAIDs. So I think there's something to be said. If your shoulder hurts, but I cause kidney damage when I'm trying to treat it, and now we have something that's a life-threatening problem to treat something that was not a life-threatening problem, that becomes an issue. And a lot of doctors are aware of this now, so we see it less and less. And so you see less orthopedic surgeons putting patients on NSAIDs for 2 or 3 years, and you see them kind of saying, hey, I need to let this be with your primary care doctor so they can keep an eye on your kidney function, keep an eye on your cardiac function, because that's not something that we normally do. And it's definitely not something I know how to do. I am not a kidney guy, a heart guy. I don't even know what tests you need to order to check that very well. So
right, and if you already have a predisposition to chronic kidney disease or stomach ulcers, it's a no-go. It's a red flag. Now the problem is ibuprofen relief. You don't need a doctor.
That's true.
You can take as much of that as you want. So I have seen patients come in and say, "Oh yeah, I've been eating ibuprofen for the last 3 years. Like maybe we should take a look at your stomach or your kidney function, make sure that's working." I mean, people have gone into renal failure because of or stomach ulcer and rupture because of this. Not to fearmonger, but it's definitely happened. Now, what I'll say is I will prescribe patients things like Celebrex or Meloxicam, which are prescription anti-inflammatories, but you take it once a day or twice a day rather than take it as you want, like you kind of ibuprofen. Obviously, there's recommendations, but also it's still short term. And if they have any of the warning signs, I won't do it.
Yeah, and I just do it. I normally say I'll give you 2 months worth, and we should either be under control or heading the right direction, or we're talking about doing more, or we have to transition to your primary care doctor to make sure it's not going to cause problems with your other medicines and things like that. Yeah. So,
is there anything else you wanted to cover on NSAIDs?
No, that's most of it. I just really like to talk to people about the fact you shouldn't be taking NSAIDs for years on end.
Right. It can be a very useful medicine, but it should not be taken chronically.
Yeah.
If at all possible.
Yeah.
So do you want to cover steroid shots next?
Oh, let's the full gambit of shots. There's so many shots. I heard this clinic is going to take my stem cells and make my shoulder better too, Dr. Davis.
Oh man, I don't know if I want to talk about stem cells today. Here's what I'll give you the short thing I say about stem cells.
Love it.
I mean, here's what I tell every patient. I say stem cells are a really cool idea. I really hope one day they work. Right now, I have no evidence to really definitively tell you that they will help you.
You heard it here. That is the important part that we will tell you. There is not evidence that this will magically create new rotator cuff tendon in your shoulder. It will also not create new cartilage magically. There's no good data to support that. Okay.
Guess what? If that existed, that'd be great. I'll be out of a job, sure, but if you...
I'd be injecting people left and right. I wouldn't have to go to the OR anymore. I'd just be in clinic every day doing injections.
There you go. That's a new business model. But that's the thing. I would love it if stem cells worked. And every now and then I have a person who comes and says, "Oh, stem cells worked. I feel great." I'm happy for you. As a surgeon who is trained to give evidence-based recommendations, I can't recommend it, and I don't provide it. And it's usually a pretty big ripoff in terms of price. Yep. And I've even seen a small number of patients get complications from it.
Okay, so let's talk about the two that do work. Let's talk about steroid shots and PRP.
All right, I'll take steroids.
You got it. I'll do PRP.
So corticosteroids. Everyone knows what a corticosteroid is, a glucocorticoid. If you start to get down to the nitty-gritty of what that is, maybe not as much. It's not an anabolic steroid.
It's not an anabolic steroid. That's important. You will not make massive gains.
You're not going to look like Arnold. That's not what it's for. It's really just a very targeted, very potent anti-inflammatory that we're delivering over the tissue with an injection. We talked about NSAIDs, non-steroidal anti-inflammatories. Well, this is a steroidal anti-inflammatory. Now, the problem with steroidal anti-inflammatories is it's because we're locally delivering them and they're so potent, they can have a very minor degenerative effect as well. And I think that freaks people out. People are like, oh, I don't want a steroid shot. That tears everything up and degenerates it. There's a grain of truth to that. And if I injected your shoulder every single day, it would be a little bit more accurate that you're having this degeneration of your tendon and your cartilage. But a shot one time or maybe even twice a year, not the end of the world. I do try to discourage it and space it out as much as possible. This is more of an acute thing that's bothering you. Should not make a habit of getting them all the time. But it's a very powerful tool that's in our tool belt to help ease suffering. And again, anything with medicine comes with risks. Yep. And if your doctor doesn't tell you that, they're leaving something out. So that's my pitch on it. It's not going to heal your rotator cuff. There's no healing properties of corticosteroid, but it can really ease your suffering and make it so you can tolerate treatment again.
Would you or have you ever received a steroid injection in one of your joints?
I certainly have on a few occasions. I had a really bad bursitis in my shoulder once, and I had an injection in my shoulder. And I also had a very bad plica in my knee, which is a band of fibrous tissue that snaps. And I got that injected as well. So I've had 2 injections in joints before. So I practice what I preach, I guess.
I've had far more than 2 injections. I'm pretty sure Dr. Davis has done 2 on me at some point in the past.
Oh, yeah.
Between residency and everything else. So
I've even scoped his knee.
He has. Dr. Davis has seen the inside of my knee. So yes, I've also received a steroid injection. I try to be very open with people about the risk involved with them. But a lot of the fear mongering and the terrible things we hear about steroid shots is exactly what you kind of said. I think some of that came from where they used to just throw like 5 times potency steroid injections in football players every week for 16 or 17 weeks. Mm-hmm. And, we've learned from that. And now that's why most people tell you can't get them within 3 months. They have to be spaced out and things like that.
And I will say as an aside, I have seen people get frequent injections in their elbow for tennis elbow. I've seen tendons rupture from that.
Yeah.
So I tell people try not to get a shot in their elbow more than once a year, and even less than if possible.
Yeah.
You can have local tissue atrophy where the skin flattens out, and I've seen people's tendons tear because of it.
Well, and that's a different injection. I do want to clarify that because normally an injection for tennis elbow is given within the tendon itself.
Correct.
Whereas a lot of the injections we're talking about that your orthopedic surgeon does are talking about within the shoulder joint or in the subacromial space, in the knee joint. Those are given into a joint space, and so there's not as much damage to the tendon itself typically. So
that's a great clarification. When we do a typical rotator cuff injection, we're sitting it above the rotator cuff between the acromion we talked about, the acromion and the rotator cuff, and that can sort of diffuse and spread out. It's not being traumatically injected versus the tendon in the elbow. There's not really much space where the tendon. You're actually injecting into the tendon and kind of spreading it out.
Yeah.
And I think that's a really good point. I'm sort of giving you the worst case scenario.
Yeah.
I think that they're safe, but like any other medication or treatment should be taken with caution. Yeah. Absolutely. Yep.
But then nerd alert here, multiple things at the same time. So we talked about impingement. That space that he's talking about that we do the injection for rotator cuff problems is called the bursa. So you'll hear people talk about bursitis in the shoulder. Bursitis, impingement, very similar things. And so I always like to tell people, they're like, well, do I have bursitis or impingement? Well, it's kind of the same thing. But that bursa is where we inject, and that's known as that space between the acromion and the rotator cuff. Mm-hmm.
So that covers steroids for the most part. I did want to say that one other sort of fearmonger scare thing. They used to do long-term infusions of lidocaine into joint spaces, and that did kill cartilage.
Oh, yeah.
But that was sort of a continuous infusion of medicine over time, and that did cause problems.
Yeah, that was cytotoxic. That was bad.
And they stopped doing it.
Yep.
So that is, there's some credence to that. But that's lidocaine. That's a little bit of a different medication.
Yeah.
So let's talk about PRP.
All right, so PRP. PRP is something that we think is promising. There is some data out there that shows it can help with tissue healing. Now, keep in mind, we are having this discussion about rotator cuffs today. This is not a discussion about shoulder arthritis because there is some data that shows with tendon healing, PRP can be helpful.
Let's just real briefly tell the difference. What's arthritis? That we're talking about.
Yeah, so arthritis, so we talk about the rotator cuff. It's the tendon around the joint. Arthritis is where you have breakdown of the cartilage in the joint. So even though we've laughed about this a couple times, we had a surgeon used to talk about looking at the end of a chicken bone. So that smooth part on the end of the chicken bone is your cartilage. That is what is in most of your joints. That, along with synovial fluid, which is the fluid between them, is what creates a low friction surface so that that joint can move smoothly and not have problems. Arthritis is when that low friction surface starts to break down a little bit.
Yeah, the cartilage starts to break down, and we start losing some of that cushioning in the joint. All right, so since we said that, I do try to define everything we're talking about.
Makes total sense.
So we'll get back to the PRP.
All right, so PRP. So there's some data that shows with tendon healing and things like that, there can be some benefit. Now, the truth is, clinically, we don't necessarily have any data that shows it is drastically more beneficial than a steroid injection. There's some people who will argue that, but there's not enough large, randomized, blinded studies, all these things we look for in research to say that this is definitely better than steroid. The big perk of it is that you lose some of the other counter effects because it's coming from your own body. So both are injections, so you can have risk of infections and things like that from breaking the skin. But we don't have any outside drugs going in a PRP situation. So in theory, you could have an allergic reaction to a steroid injection. You shouldn't really to a PRP injection. Steroid injections in diabetics can raise their blood sugar sometimes.
I'm so glad you brought that up. I forgot to bring that up.
Yeah, I was going to say, diabetics, sometimes they get that steroid injection, their blood sugar goes through the roof. So that's something we ask every patient before we inject them.
Absolutely.
To make sure they know. Now, it's normally for a short term, but it can happen, right?
If you're sitting on blood sugars of 300 or 400 and I give you a steroid shot, you could end up in the hospital potentially.
100%.
So that's definitely something that we ask every single patient.
Yeah. And so PRP, that's not the case necessarily. Now, it takes a little longer. You have to have your blood drawn. We have to spin it down and things like that. But in theory, they both can help with decreasing inflammation in the shoulder. But there's not anything at this point that I would say proves that it actually makes your rotator cuff heal back.
What's the other big downside of PRP?
Biggest downside is that PRP is not covered on most insurances. So you're talking cash money payment out of pocket.
It's mostly the technology that is the cost. Even though they're drawing your blood, it's the centrifuge and the tech that goes into it. And that's just the manufacturers require a fee to be able to use it. Yep. And unless you're VA in most situations, I think.
Oh, I don't know. I didn't know that they covered it.
I think occasionally VA or TRICARE may cover it. But most insurances, it's cash pay only.
Yeah, that's because our great men and women of service deserve it.
Yes, absolutely. I think that it's maybe one day we'll see more of it, but we talked about evidence-based, right?
Yeah.
We'll see some papers that say there's a benefit. We'll see some papers that say there's no benefit. There's not a consensus on this by any means.
Well, and nerd alert, getting into the weeds a little bit, there's all kinds of different formulations. There's high white count, low white count, all this stuff. And so people are doing all kinds of things trying to figure out what the right way to do it is that gets the biggest benefit. And the truth is, we don't know. Now, I'll be very open. I've had a PRP injection, actually. We mentioned Dr. Davis. He was the fourth person to go in my knee. So I'm a couple surgeries in.
That's a bad sign, by the way.
That's a very bad sign. Yeah. So the claim to fame for me in residency was at the end of residency. One of the docs, who is now my partner, gave a speech and said that Dr. Givens loves orthopedic surgery so much. He tried them all because I've had 7. But I've got some arthritis in my knee.
I've only had one.
Only one for you? Man.
I had a septic hip when I was 7 years old. So
that doesn't even count.
It's an orthopedic washout.
It's an orthopedic washout. That's fair. But so I'd had steroid shots. They help, but for a limited time. Being young, I'm trying to avoid my total knee that will come eventually. So I was just looking to see what's another option I can try. I tried the PRP. I think the important thing about it though was that I did it with an extensive rehab protocol. Mm-hmm. So I do feel better. That could just be because it decreased the inflammation and allowed me to build the muscle back to help support my knee, because I just had so much inflammation I couldn't do some of the muscle building stuff before.
Yeah.
So
I think you touched on something that's going to really kind of broadly cover this, is the rehab.
Yeah.
The rehab is so important. If you tell me I cannot go through the rehab, that's one reason you may want to think twice about surgery. If you're going to go through all of this pain and suffering and expense of having a surgery on your shoulder like a rotator cuff, you're going to have to put in the work, because you're going to be stiff, you're going to be sore after surgery. You got to get that strength and range of motion back after we fix your rotator cuff. So that is definitely something that plays a huge role in this. And if you're like, I just don't think I can go through the rehab, and I'll grant you, this doesn't happen very often. Most people say they understand, But again, it's all about that managing expectations. I tell people it could take 6 to 9 months to be fully recovered from your rotator cuff. That varies from person to person.
I agree. But here's the thing, Doc. All this non-op stuff, I don't want to do it. I've already tried it all. I don't feel better. Talk to me about the big thing now. I want you to cut me open. Let's do it.
Okay. So we're almost out of time, so we may have to split this into another episode, but we're going to keep churning until they stop us.
I like it.
Okay. We've decided to go through with surgery. The standard of care for rotator cuff surgery is now to do it arthroscopically through small incisions. Back in the day, we did it open. Some people still do something called a mini open where they make a small incision and repair it that way. There's a lot of debate on what's better. I find that my patients recover better, have better cosmesis, and have less pain and less complications when doing it arthroscopically. In this day and age where Dr. Givens and I were raised doing this, where when we were residents this is how we learned to do it, I think that it's become easy for us. But when you first transitioning to that as a new technique, I think that can be very difficult.
Yeah, 100%. So if a doc says that they do what's called a mini open, is that a problem? Should I look elsewhere? Or is there data that says it's better if I have it with the scope?
I think I'm going to get in trouble for saying this because I know people who do it mini open. Long term, probably not a whole lot of difference, but short term, there is difference. And there is data that shows higher complication rates for mini open.
Yeah. And I think it's important to remember that it's what's best in your surgeon's hands. But sometimes people have asked me that, and it's like, look, looking at a wide perspective, maybe, but I wouldn't force my doc to try to do it a different way. Most of the time, if they've chosen a technique to do something, it's because that's what works best in their hands. And I've seen some guys who do it mini open still that have great outcomes, but it definitely is a question I've been asked by more than one patient.
Yeah. And I'm biased. I do it arthroscopically. I think that they do better, they feel better, they recover faster, and they look better, the incisions. So all the above, I say do it arthroscopically.
100%. Look, you can't see mine. You can't see my incisions.
Did I close that one too?
No, you didn't do this one. You didn't do this one. But you can't see my one on my knee. Dr. Davis, a plastic surgeon level closure skills for a scope
hands.
portal. I'm telling you, those big meat hooks can work.
So at baseline, we're doing it arthroscopically. It's generally an outpatient procedure. You're going to go home the same day. You're going to be in a sling. We can do a long-term nerve block where you don't actually have much pain in the first 2 or 3 days after surgery. And then we do our best to wean you off of pain medicines, keep you on narcotic pain medicines as short of a time as possible. And we've actually gotten a lot better at that in the last decade as well, in terms of multimodal pain control, where we're not going to have you on such heavy narcotic pain medicine. And I can tell you it'll vary from patient to patient. I'll see patients in slings anywhere from 4 to 6 weeks after surgery. We're getting better and better at having more secure fixation techniques that we talked about, that we may even be looking at 1 to 2 weeks in a sling now. I'm not going to make any promises. I'm not there yet. But
we don't need to go there just yet.
It may be coming. It may be coming. We'll see. There's a lot of really interesting technology. But with integrated approaches with anesthesia, with the surgeon, with therapy, I'm seeing patients recover faster and faster than we ever did 10 years ago.
Yeah. And I think this is where it's really hard. There's a lot of things where we talk about advanced protocols and faster rehab. And, I talk about it all the time. My patients after a shoulder replacement are in a sling for 7 days, and they get moving and they love it so much.
Now that's a shoulder replacement.
Shoulder replacement. Okay. Exactly. The rotator cuff is still hard because unlike other surgeries where I just need your skin to heal, I need that tendon to heal, and it heals slow. And so even if we can let you get moving a little quicker, there is definitely some time where you're not allowed to lift heavy because we need that muscle to not be engaging heavily so it doesn't pull on that repair to an extent. So if we're talking about recovery here, how long is your patient going without lifting? Maybe I can come out of the sling early, but how long until I can, hit the gym again or throw 100 pounds over my shoulder at work?
So every surgeon is going to be different. Every single therapist protocol, every surgeon is going to have a little bit different, and it may even depend on the size of your tear. Yeah. We talked about 4 tendons. If it's just 1 tendon or 2 tendons involved, that may change how your surgeon decides to approach your rehab protocol. I will give you some general answers.
That's all I want, just general
When you
here.
Listen to this podcast, do not go talking to your surgeon and say, well, he said you could do this. It's patient dependent and tear dependent.
No, I'm going to say Dr. Caleb Davis on the Shoulder Blueprint podcast said I would only be this long.
Hey, as long as you're spreading the word about the show.
We're going to start getting hate mail.
Yeah. In general, for a large tear, I put my patients in a sling for 6 weeks. Then I have them start doing what's called active and passive range of motion with no weight bearing. So they're firing the muscle of their shoulder and someone else is moving their shoulder. I don't usually do any resistance training until about 3 months. So 3 months total. Now that's a little bit on the conservative side. Some people will take 2 to 5 pound weights or some light bands prior to that. But the data would show that the tendon, even in a perfect situation, is not fully healed at 6 weeks.
Yeah.
It takes about 3 months for that tendon to fully heal. So I don't like to go putting a lot of stress on it till 3 months. And then I'll let the therapist and the patient decide together on how fast to advance their strength training after 3 months.
Yeah. Yeah. I'm very aggressive. I'm open about that. But the one thing you can't argue with is trying to pull on things that aren't healed all the way. And so I'm very similar. I don't allow a ton of resistance training. I've had some therapists that I trust that they'll move forward a little earlier, very slowly, but you're talking at least 2+ months of no significant resistance. And if we're talking about getting back to like real stuff, working out, moving heavy labor at work, you're really talking 5 to 6 months. I mean, I need to know that not only is it healed, but you've re-strengthened some of those muscles, because that's a great way to hurt it again, is to not have the requisite strength to do the job.
A lot of those other muscles have atrophied while you've been immobilized.
Yep.
And then you could just get hurt again, even if everything healed. That's right. I would be remiss if I did not talk about nutrition just a little bit, because we talked about tendon healing. I'm big on nutrition.
I know, and I love it. It's a good thing, but I just like to eat in general is the problem.
Well, a lot of our patients are actually calorie deficient, believe it or not. Or
I'm not.
I know you're not. Neither am I. You can tell. But a lot of times we're going to focus a lot on older patients, but you lose the drive to eat, especially a lot of protein. And a lot of protein is going to carry a lot of the building blocks for how letting these tissues heal. Micronutrients as well, things like vitamin D, magnesium. Zinc is a big one I think people don't talk about. Everyone's heard of vitamin D, but zinc is another one I've been pushing a lot lately to help with these tissue healing factors. So I'm not sponsored by anybody, but there are companies now who are offering whole surgical nutrition packages. You can shop and piece it all together for yourself and get it a little bit cheaper, but surgeons are recognizing that this is essential and actually may help patients have better outcomes by getting them more protein and vitamins and micronutrients.
Yeah, 100%. I mean, there's a group of shoulder surgeons that are involved in one of those, and that was kind of what they built this around, because they realized their patients, you can do everything right, and if you don't have the nutrition to heal it, your body's not going to heal it. There's no way that we can make that jump to do that just by fixing something. We talk about things like preventative health and stuff like that. In our world, we don't really have great preventative health in the orthopedic realm, because most people come to us already broken. That's the reason they're there. So we have to fix it, but we can do things to help make that healing better. And that's kind of what you're talking about on the nutrition side. If you don't have the building blocks to heal it, once we get it fixed back, it's not going to heal.
That's right. What we said before, you can lead a horse to water, but you can't make it drink. We can pull that tendon back down to the bone. We can put PRP in it. We can do these patches. But if the bone and the tendon have to join back together.
They have to. Yep.
And if the body doesn't have the building blocks to do it, there's not much else we can do. So I would encourage you, if you're seeing a surgeon and discussing surgery, to at least have a discussion about preoperative nutrition. If you come see me about it, Dr. Gibbons, we can talk to you about it too. I'm very passionate about it, so I'll get off my soapbox on that.
That's okay. It's a good soapbox to be on. Because once again, really as a physician, we should be taking care of the whole aspect of the patient. And me personally, there's a lot more to this. We've talked before about how I'm really into like the whole other side outside their shoulder, from the spiritual side to the emotional side, and the nutrition side. If we're really trying to be the best physicians we can, we're looking at all these things, because if you can help their overall nutrition, you might not just help their shoulder heal. You might help some of their other problems as well.
Yeah, absolutely. You can see a whole quality improvement of life. We should do an entire episode on how community and spirituality and mental health affects physical health. That would be a great episode.
I would love it. You know my premise on that, and so I think it'd be a great one.
I wanted to end every episode, and we'll see. This is a shifted dynamic with a shoulder myth buster section, and we've already covered some of these, but I'm gonna take a look.
Okay.
Steroids fix rotator cuff tears.
Myth: steroids do not fix rotator cuff tears. Steroids decrease inflammation and some of the pain, and then maybe allow some of the other muscles to strengthen to help hide the rotator cuff tear a little more.
That's right. Then number 2 was you cannot strengthen a torn rotator cuff. I'll take that one. So while it's true that if there's a tendon torn off from bone, you cannot convey force to that torn tendon. However, the rotator cuff, as we discussed, is made up of 4 muscles. And even you can have a partial tear and you can still strengthen the muscle attached, and you can still strengthen the surrounding 3 muscles. And more importantly, you can surround all of these different surrounding muscles that attach to the shoulder: the pec, the deltoid, the latissimus, the teres major. the trapezius. All of these different muscles can be strengthened and help improve your shoulder health. All right, myth number 3: wait until it's unbearable to fix it.
Ooh, myth. And the reason I say that is I think this is not a discussion we make without more in-depth analysis. So we know that some tears actually, if you have a full thickness tear, if you wait until it's unbearable, it might not be fixable anymore.
Why is that? We didn't cover this.
We didn't yet. So this is where it comes into muscle atrophy. So to give you a reminder of going back to the anatomy, we're talking about the rotator cuff tendon. When we call something a tendon, that means it is a muscle, and the tendon is the portion where the muscle gets thickened and connects to bone. So whenever we talk about the rotator cuff tendon, there's a big muscle over here, and that's what does the work. The tendon is just how it connects. And so I like to tell people, if you've ever seen someone who has had an unfortunate event, become paralyzed or something, and their legs atrophy away, and you can watch that muscle disappear, that's what happens to your rotator cuff. The problem is the rotator cuff is such a small muscle that once it atrophies away, there's no way to really bring it back. So, once again, I speak redneck. That's what we've kind of said. So I always like to tell people, fixing a tendon that doesn't have a good muscle is like hanging the Christmas lights but not plugging them in. It's not really going to do anything for you. So I don't think you have to let it completely become unbearable. If you think you have a significant rotator cuff tear, or especially if you have a big trauma that creates a new injury, you really need to get it checked out to make sure that you're not going to completely make it unfixable if you wait too long.
And the hope is that your surgeon will sit down and consider all the different factors of your life and try to help you come to a decision on whether or not you need surgery.
And just so we're clear, that is not the hope. That is the standard. Your surgeon should go over this. It's called informed consent for a reason. We cannot make you shoulder specialist in 15 or 20 minutes. But if we know the things that we need to know, we should be able to talk you through this and at least give you a general idea of what's going on.
Next myth: all rotator cuff repairs fail eventually. I'm going to say myth. Now I understand why this is something that people think.
Yeah.
Rotator cuff tears have a fairly high failure rate. Not as high as you might think, but higher than we want. And we talked about all the reasons that this is the biology, the nutrition, the blood supply, and this is something that you would have during informed consent with your surgeon, talking about what's the risk of a failure here. Yeah. But I think there are studies that have showed long-term that patients have had good function, good strength, and MRIs proving that their cuff tears are intact. Now, I don't know how many studies have 20, 30, 40 MRI years later get an MRI to show it, but what I would really say is I've seen patients have great function and strength years and years and years down the road of their rotator cuff, whether I have an MRI to prove it or not.
It's hard because you're talking semantics on the wording here. I would say that all rotator cuff tears or all rotator cuff repairs fail eventually. That is a myth. All rotator cuffs fail eventually. That, I think, is a fact if you live long enough.
If you live long enough.
Because I've definitely seen people that had a rotator cuff repair and came to me down the road, and the area of their repair was healed, and they tore in a different place.
Sure.
And it was 15, 20 years later. I've had a couple patients that have young traumatic tears, and I fixed them in their 20s, and I try to tell them, hey, your rotator cuff still has a chance to tear in the future, completely unrelated to this tear, just because we know that there's going to be degeneration of that in the future.
The last one I have on my list.
Oh boy, I see the smile on his face. He's just ready to drop this one on me.
It's the most painful surgery you can get. That's a tough one because pain's subjective, right?
Pain is subjective. I do tell my patients that it is one of the most painful shoulder surgeries you can get. Now, that's very skewed because most of the patients coming to me worried about pain are coming for what we call elective surgery, which means they're coming for things that maybe you can do surgery, but you don't necessarily have to. I would still argue that some of the most painful are my fracture dislocation patients who've broken their arm or dislocated, but they don't consider theirs elective. They got to fix their arm because they're in excruciating pain. So of the elective surgery group, I would say that rotator cuff repairs can be one of the most painful, but I don't think it's pain. I think it's annoyance.
I hear that a lot. I'm in the sling. I'm sweating. Oh, can you get the sling off of me?
Yeah,
Yeah.
it's like, the most common thing I hear that my patients need pain medicine for is, Doc, I just can't get comfortable to sleep in
Can't
this
sleep.
sling.
Yep.
This sling is killing me. I can't get comfortable. And I'm like, well, how much does your shoulder hurt? Well, just everything hurts. My back hurts because I'm sleeping in the recliner. My neck hurts from the sling strap. So I think it's definitely one of the most annoying, because if you've had a fracture and your arm's broken and it gets fixed and you have to set in a sling, your pain gets a lot better than it was. So you're like, hey, I'm letting this heal. I get it. When you came in and you were moving your arm pretty well, it was just painful all the time. And then we put you in a sling and tell you can't lift for 3 months. People get annoyed. They want to get back to life.
I think that's a good point. I'm going to call this myth mostly true. It's not a myth.
I was going to say myth,
sorry.
mostly true. Hold on. Is it a myth or not?
I'm going to call this one mostly true. I say the same thing. Like, yes, out of all the surgeries I do, this is probably one of the more painful ones. But optimistically, I'm going to tell you, I'm seeing it get better with things like patch augmentation, with things like the long-lasting blocks. I am seeing people tolerate the pain better. Also with multimodal pain control. Yeah. Things like a combination of anti-inflammatories, Tylenol, muscle relaxers, maybe something like gabapentin, outside of narcotics, and using this sort of broad spectrum of controlling their pain and making them comfortable. I'm seeing patients suffer less and less as we progress down that road.
I think so. You're going to learn things about us through these podcasts that are kind of our sticking points. Pain is one of my big things I talk about. I don't think I'm being a good quality of life surgeon if I'm not appropriately managing the pain and not creating other problems through pain medicine. So
we don't want to cause addiction and dependence.
Exactly.
Right?
And so I'm a very big stickler on pain meds. I watch closely how many we take, and I try to do a lot of things to prevent using them to every extent. And I will say, as much as we talk about it being an annoying surgery, I'm still surprised by how few pain medicines my patient need after a rotator cuff repair. And I think there's a lot to that. We've had these discussions before, and maybe we can dive into this more on Rotator Cuff Part 2, where we talk about the repairs more in depth. But I think there's way to make sure you're not over-tensioning the cuff. There's ways to make sure that you're doing a good repair. There's ways to make sure you're treating the other pathology. A lot of people come to me. I had a patient just recently come for a second opinion because their shoulder was killing them after the rotator cuff repair because they had a tear in their bicep that wasn't treated. Mm-hmm. And so we ended up doing an injection in their bicep, and it took away all their pain. It was something that was left out as part of their surgery. They didn't kind of treat all the pathology. And I think some of that can come into play at times as well.
I think that's a great way to wrap up. Dr. Givens, thanks so much for joining. You can look forward to more episodes of the Shoulder Blueprint in the future. Our goal is to be do twice a month, but we're both busy surgeons, so I can't promise. It may be a once-a-month episode. We would love to hear topics and questions, not personal medical questions, but general questions that you'd like us to cover on the show. We have an Instagram at Shoulder Blueprint. You can also find me at Caleb Davis MD at almost any social platform. Dr. Givens, give us your social handles.
Givens Shoulder Elbow on Instagram, or check out LinkedIn. I don't have any others than that. My wife's the social media guru, not me.
Probably best to leave it to her, right?
Yeah, best to leave it to her. But if you want to see other cool content or things that we do, so I post a lot of the surgeries I do, a lot of the different things that we do that are educational. We both like to teach and do those kinds of things. You can normally find that because we have a little more surgeon involvement on those things. They want to be able to tune in and look at the cases we're doing and see tips and tricks anytime, as opposed to maybe sitting through a 45-minute podcast.
Yeah. Hey, but you can drive down the road, listen to these two nerds talk about shoulders. What a great way to spend a drive.
You know what? I think we should just start playing it in the OR. That way everyone can gain from our knowledge. You know, I would love to listen to myself the whole time that I operate. That would just be amazing.
Man. You could also email info@calebdavismd.com if you'd prefer to just email us directly. And we can also try to cover your topics or answer your questions there.
All right. One last fun question because I brought it up. OR playlist. What's normally playing in the OR?
Man, I'm a kind of a pop punk guy. Like Green Day, Sum 41, Good Charlotte. It kind of gets me amped up. Feels like I'm back in the 8th grade.
Oh, okay. That was not what I was expecting.
All right. He wants to say that I listen to classical music because I'm a classical cellist and I used to be. Guess what? No one else in the OR wants to listen to that. What about you?
So I'm very open that I have 2 rules. There has to be a beat, and there cannot be spoons, because I had a co-resident that made me listen to 45 minutes of someone playing the spoons on their leg. But most commonly because of the people that are in my room and because some of the things I like, the girls in my room love some Taylor Swift. So I've heard all the Taylor Swift songs, heard the new album, all of that jazz. And then me and some of the guys really like Forrest Frank. So we have Forrest Frank blaring a lot too.
You got to keep the team happy. That's the most important part.
Most important thing is keep the team happy.
That's why I'm not playing Beethoven in the OR.
Every now and then, right? When you need to mellow it out. But I do like the beat. I need something a little more rhythm, a little more upbeat normally.
Spoons might be the only thing more boring than our podcast.
That's true. That's true, because even classical music's probably a little more interesting than two nerds talking about shoulders.
A little bit. All right, we're going to wrap up there. Thanks, everybody, for listening. We'll see you next time. If you have any questions or want to reach out, our email address is info@calebdavismd.com. Follow me on Instagram, X, and TikTok @CalebDavisMD. And subscribe to our YouTube channel, Caleb Davis-MD. You can also follow Dr. Justin Givens @Givens Shoulder Elbow, and check out our podcast Instagram page @Shoulder Blueprint. And if you haven't yet, explore my other podcast, The Wellness Blueprint with Dr. Caleb Davis. Thanks for listening, and we'll see you next time.
The views and opinions expressed on this podcast are entirely our own. They do not represent the views of our employers or any professional organizations we're affiliated with. Nothing you hear on this podcast should be taken as medical advice. This content is for educational and informational purposes only. If you have a medical concern or health problem, please consult a qualified physician.